In this particular section, we will be talking about non-resolving pneumonia. Now, as the name suggests, non-resolving pneumonia, that means pneumonia that is not resolving. So, by definition, this is a clinical syndrome in which focal infiltrate begin with some clinical association of acute pulmonary infection. In other words, in a patient of community-acquired pneumonia, if there is no clinical response after 10 days of antibiotic therapy or no radiographic improvement after 12 weeks, then that signifies what non-resolving pneumonia is. Again, it's a clinical entity where despite a minimum 10 days of antibiotic therapy, patients either don't improve or worsen or radiographic opacities fail to resolve within 12 weeks. Now, interestingly, approximately 20% of the patients who are suffering from community-acquired pneumonia, who are non-responders, they have a non-infectious etiology behind them. So, when you talk about resolution, what does that mean? There are certain clinical features. Say, for example, the features that take most time to improve includes cough and fatigue, which takes place approximately in 14 days. Improvement in tachycardia and hypotension is the earliest, that is in just 2 days. Resolution of fever, tachypnea, and arterial oxygen takes approximately 3 days. Another important point to note is that if you are treating a patient on OPD basis of community-acquired pneumonia and he or she does not respond to the treatment even after 48 hours, then that patient should be admitted and chest X-ray in these patients should be done. So the next question is, what do you actually mean by slow resolution when it comes to radiology? Now, slow resolution means persistence of radiographic abnormalities for a greater than 1 month in a clinically improved host. So if you have a host who is clinically improved, but still there is radiographic abnormality persisting for beyond 1 month, then this includes what slow resolution is all about. Now, how do you diagnose a case of we'll be getting back to the diagnosis, but first, let's understand what are the various causes of slow resolution. Now, the causes of slow resolution could be broadly divided into host-related factors and pathogen-related factors. So first, we'll talk about comorbidities. Now, patients who do not have any associated medical illness, they have normally a clinical or radiological resolution, I must say, in 4 weeks. If you look at the age, 90% of the patients who are younger than 50 years of age, they also have a radiological resolution by 4 weeks. When it comes to severity, radiographic resolution in severe pneumonia can take up to even 10 weeks, right? So this is to be kept in mind. Then we come to the infectious agent. Now, it has been seen that in cases of mycoplasma pneumonia or in non-bacteremic type of strep pneumo, the resolution is rapid. And so is also the case in cases of chlamydia and Moraxilla catarrhalis as well. So on this note, let's talk a little about the various pathogens which may cause it. So first we'll talk about strep pneumo. Now strep pneumo, as we understand, is the most common cause of community-acquired pneumonia, but at the same time, it's also responsible for most cases of non-resolving pneumonia as well. So obviously there might be certain risk factors associated with clinical deterioration or lack of clinical improvement, and there would be certain risk factors that would cause the lack of radiological resolution, right? So the risk factors for delayed resolution or clinic of auscultatory findings or clinical improvement includes a more severe presentation, number one. Number two, multilobar disease and infection with drug-resistant organisms, right? So these are the factors associated with lack of clinical improvement, more severe presentation, multilobar disease, and infection with drug-resistant organisms. Then risk factors associated with delayed radiographic resolution. This includes bacteremia, number one. Number two, persistent fever or leukocytosis beyond 6 days. That's number two. Number three, advanced age. Number four, COPD, alcoholism, and HIV. So these are the risk factors which may cause a lack or delayed radiographic resolution. I repeat, which includes bacteremia, persistent fever, leukocytosis beyond 6 days, advanced age, COPD, alcoholism, and HIV. Then thirdly, we have radiographic clearing. Now, importantly, radiographic clearing in cases of non-bacteremic strep takes place in 1 to 3 months, whereas in the case of bacteremic strep, this may take approximately 3 to 5 months. Then we come to Legionella. Now, Legionella, as we all know, happens due to exposure to droplet infection, aerosols which contain this bacteria. Most of the times this is seen in patients who are working with humidifiers or air conditioning systems. But yes, cigarette smoking, alcoholism, and an age of more than 65 years, along with immunosuppressive states, especially the patients who are on glucocorticoid use, patients suffering from chronic kidney disease, and patients who have undergone hematopoietic or solid organ transplantation, can be infected by this organism. Interestingly, in this condition, we see that despite the treatment initiation, there is obviously the clinical improvement. But after the initiation of treatment, for some time there is a radiographic deterioration as well. So, after the initial deterioration, resolution starts taking place at approximately 2 to 3 weeks. And half of the patients demonstrate residual abnormalities even up to 10 weeks. The resolution may take as long as 6 to 12 months, and residual fibrosis may be evident in up to 25% of the patients even at the end of 1 year. And it has been also seen that these residual abnormalities are also demonstrated in PFTs as a restrictive pattern in patients as long as 2 years after the infection. Then we come to Mycoplasma pneumoniae. The Mycoplasma pneumoniae, as already been stated, has a rapid resolution, and the average duration of radiographic improvement is 2 to 4 weeks. 40% of these patients have complete radiological resolution at the end of 4 weeks, and 90% of the patients have complete resolution at the age of 8 weeks. Then coming to Chlamydia pneumoniae. Now, Chlamydia pneumoniae, as we know, is more seen in residents of long-term care and facilities and in military recruits, has a relatively mild disease, and clearing typically occurs in less than 3 months. Then we come to H. influenza. H. influenzae, they are seen in older adults, in patients who are cigarette smokers, and in patients of COPD. But with the advent of vaccines against H. influenza type B in children, there has been a decreased evidence of incidence of infection and a shift to the non-typable strains of H. influenza. Now, these were the infective causes. Apart from that, there could be some misdiagnosis of pathogen as well. In cases of diabetics or in older adult patients who, there could be an atypical presentation of tuberculosis as well. Tuberculosis in India is one of the leading causes of non-resolving pneumonia, and uh, TB may have an atypical presentation, like I said, especially in cases of diabetics and older adult patients, where you may see radiographic findings in the middle and the lower zones, as against the usual consensus, where we find TB in the more in the upper zones. Apart from that, patient may also have fungal infestation, where these patients may demonstrate a rounded or mass-like density with or without cavitation. Aspergillus is a very important organism causing this, especially invasive aspergillosis, which is seen normally in neutropenic patients who have been on multiple antibiotics for several days, but it has also been seen in older adult patients with chronic lung disease who are on corticosteroids. Apart from that, nocardia and actinomyces also give fungi-like lesions on the radiology. Then you may also encounter resistant pathogens. These can be suspected in patients who are not responding appropriately to antibiotic therapy. Then, apart from that, we already touched upon certain host factors, but yes, AIDS or immunocompromised state is another reason. The patient can have either acquired immunodeficient states, or the patient might have some primary immunological defect in the form of X-linked A gamma globulinemia, common variable in immune disease or CVID, and selective immunoglobulin, especially IgG subset deficiency. In these patients, there is more chance of development of pneumonia due to strep pneumo, H. influenzae, mycoplasma pneumoniae, and Pneumocystis jirovecii rarely. Now, there could be also the non-resolution could also be due to complications from the initial pneumonia. That is, patients who are suffering from empyema or lung abscess. Now, empyema is generally seen in younger patients with a history of illicit drugs, but obviously in patients with TB, this may complicate as well. In these patients, the demonstration of any significant amount of pleural fluid should always prompt you to consider pleural tapping and rule out empyema, right? So even the slightest collection in these patients might be needed to be drained to check out if the patient has empyema, because if the patient would have empyema, then in that case obviously you need to drain it as much as possible. Then we come to lung abscess. Now, lung abscess, as we all know, are due to anaerobes, could happen as a result of aspiration pneumonia, and this aspiration pneumonia eventually progresses, as we all know, to necrotizing pneumonia and later on lung abscess, right? So this is the fate of aspiration pneumonia. Either it is going to cause necrotizing pneumonia and eventually it is going to cause lung abscess. This condition, as we all know, is seen in patients with a history of alcoholism, patients with past history of seizures, poor oral hygiene, and previous aspirations. Uh, the organisms suspected in this category include Peptostreptococcus species, Bacteroides species, and Fusobacterium species. At times, in patients of lung abscess, you might need a more aggressive approach. This may especially be seen in the patients of extreme age groups, that is, pediatric and old age populations, patients with a larger cavitary size, longer duration of symptoms prior to therapy, lower lobe location, patients with associated malignant disease, and also patients with multiple abscesses, right? Then, apart from that, there are certain other conditions, or what we say as non infectious etiologies, which may cause a slow resolution. Now, this includes neoplastic disorders, inflammatory disorders, drug induced lung disease, pulmonary embolism, and hydrostatic pulmonary edema. So, we'll take a look at them one by one. So, when you talk about neoplastic disorders, most of the times in these patients, the non resolution occurs due to some compromise of the airway lumen, right? And as we said, it could be either due to some external compression or there could be some intraluminal growth, which eventually causes secondary post obstructive pneumonia or maybe in some cases even an abscess, right? So, broadly, the type of pneumonias, so the type of cancers which we come across in the lung, this includes bronchogenic carcinomas now and carcinoid. Now, most common causes of endobronchial obstruction include bronchogenic carcinomas and carcinoid tumors. These are the most common cause of endobronchial obstruction. When you talk about bronchiolo-alveolar carcinomas, uh, that is adenocarcinomas in situ, and lymphomas, they are the most common causes of an alveolar infiltrate mimicking pneumonia. So, major airways, when we talk about bronchogenic carcinomas and carcinoids, are important, and when we talk about alveolar infiltrates in these patients, bronchiolo-alveolar carcinomas and lymphomas play an important role. Important thing to remember is that bronchiolo-alveolar carcinomas may present with a discrepancy between the size of the infiltrate and the paucity of systemic symptoms. You might not have a lot of infiltrate on the chest x-ray, but this your patient might have severe symptoms. So there can always be a discrepancy between the size of the lesion and the symptoms of the patient. Then lung adenocarcinoma, this may present as a focal infiltrate, often with air bronchogram. So patient with an air bronchogram does not always should need not always be considered a patient of consolidation. You should always rule out carcinomas whenever you're suspecting these patients. Then the fourth type which may cause a non-resolving shadow includes lymphomas. Now, especially in lymphomas, low-grade B-cell lymphomas arising from mucosal tissue, that is MALT, high-grade B-cell lymphomas, and lymphomatoid granulomas, right? So these are broadly these are the ones which include all these, which may cause non-resolution of symptoms. Just a few corrections. Then, right, so low-grade B-cell lymphomas, high-grade B-cell lymphomas, and lymphomatoid granulomatosis. Then primary pulmonary lymphomas, they are quite unusual and they constitute only 10% of Hodgkin lymphomas. Primary pulmonary lymphomas we're talking about. Then, after discussing neoplastic disorders, let's come to inflammatory disorders. Now, this includes number one, the vascular causes, that is vasculitis, that is Wegener's and other causes. In these patients, bronchoscopy and BAL that should be done. Wegener's, as we all know, patients may present to you with cavitary diseases, recurrent nasal bleeds, and fatigue, and may or may not present as hemoptysis. And obviously, in these patients, PR3 IgG is positive. That is CNCA in these patients is positive. Then COP is another entity, that is cryptogenic organizing pneumonia. Patients would have a flu-like illness and there would be elevated ESRs and leukocytosis along with patchy alveolar infiltrates, and the symptoms are less than 2 months at the time of diagnosis. Then your patient might be also suffering from eosinophilic pneumonias, which include both acute and chronic, where patients have bilateral infiltrates and they have a good response to steroids. Then patient might also suffer from acute interstitial pneumonia, which is an idiopathic form of diffuse alveolar damage, and the patients have a prodromal period of up to 14 days with the onset of fever, cough, and dyspnea. And chest radiographs most of the time show a bilateral airspace disease along with patchy or diffuse areas of GGO in cases of in HRCT. Then another entity in inflammatory causes is pulmonary alveolar proteinosis. We have seen this happens due to accumulation of surfactant where your macrophage is not actually working well, and these patients classically present with milky proteinaceous pass positive material on BAL, and on CT they have a crazy paving pattern. In cases of autoimmune disorders, you may be able to demonstrate autoantibodies against macrophages, that is anti-GM-CSF antibodies may be may be seen, and they have a lower and mid lung zone predilection. And obviously, lastly but not the least, sarcoidosis is another cause. Then, apart from that, we have drug induced lung diseases. This includes the classical ones, that is amiodarone, methotrexate, nitrofurantoin, and bleomycin. Amiodarone causes acute presentation with focal alveolar infiltrates, so that is again very important. Then, anti tumor drugs may also cause this. This includes classically the anti TNF alpha agents, which includes etanercept, etc. Then, EGFR positive anti EGFR patients who have tyrosine kinase inhibitors, which includes erlotinib, gefitinib, etc. Then, we have mTOR receptor inhibitors like everolimus, which is specially used in cases of progressive renal cell disease. Then we have pulmonary embolism. Pulmonary embolism is another cause of this, and pulmonary embolism may present to you with as pulmonary infiltrates in up to 30%, and may present may the uh, excuse me, yeah. So Uh, uh, so yes, in these patients, we patient may present to you with pulmonary infiltrates in up to 30% and pleural effusions in approximately 20% of the cases. And these patients may take several weeks to dissolve, and they are easily mistaken for slow resolving pneumonias. Then we have another entity, that is hydrostatic pulmonary edema. Now, most of the times when we talk about pulmonary edema, it is a case where patient has characteristic curly B lines, and there is bilateral butterfly type of a lesion, and there is cephalization of great vessels. So all these things are seen normally, but in patients, there could be also focal radiographic patterns of pulmonary edema then that may mimic pneumonia. Now, this generally happens in areas of increased perfusion, and this happens in the cases of bullous lung disease or in cases of mitral regurgitation, right? So, uh, the patients with severe COPD, that is, they may also manifest with asymmetric patterns of pulmonary edema, because in these patients also there is always a case where there is maximal perfusion appears most prominent in the areas of maximal perfusion, like we said. So these patients also may present to you as a patchy infiltrate on the X-ray, right? So after discussing all this, let's come to the approach in diagnosing these patients. So, whenever you have a patient who is not resolving or not responding to your antibiotic therapy, and there is no radiological improvement even after 1 month, you got to go back and take a careful history. Again, examine the patient for some other cause and review the medical records as well. In a patient which we are dealing with is a stable or slowly improving pneumonia, a careful observation with or without therapy is warranted for 4 to 8 weeks. You need to observe this patient for 4 to 8 weeks, even if the patient has completed the treatment. Now, if you do a bronchoscopy in these patients, and if a bronchoscopy gives you a negative response, negative examination on bronchoscopy, then there is a good chance that this patient is merely having a slowly resolving pneumonia. Particularly if there are smokers or if the age is more than 55, then obviously in these patients the radiological resolution of pneumonia would be definitely slow. Then imaging studies are very important as an approach to the diagnosis, because these may highlight to you as sequestered foci of infection. So when you have sequestered foci of infection, the sequestered foci by definition means either lung abscess or empyema, right? And also at the same time, this also helps you to direct biopsy procedures. Then bronchoscopy, well, bronchoscopy with BAL and transbronchial biopsies, they can successfully diagnose approximately 90% patients who eventually have specific diagnosis established, right? So in a study from India, it was also observed that pyogenic infections were the most common cause of non-resolving pneumonia, followed by bronchogenic carcinomas and TB. Uh, but in cases of pulmonary vasculitis syndromes, COP, and diffuse alveolar damage or various other etiologies, you may not get a typical diagnosis by bronchoscopy, right? You may need to add some more tests, right? Then thoracoscopic or open lung biopsies, they are indicated in if the patient had a previous non-diagnostic bronchoscopy. So in these patients, or if you require a larger specimen for further evaluation, only in these patients, you're going to go for thoracoscopic or open lung biopsy. Or if there is any contraindication of bronchoscopy, a patient cannot undergo a bronchoscopy. In these patients, it is very important. So after that, let's come to the comorbidities and associated with delayed resolution of pneumonias. So uh, these are the conditions and these are the reasons or its effects which may lead to a poor resolution of pneumonia. So, like we said, COPD. In COPD, the patients have impaired cough and mucociliary clearance. This is the cause of non resolution. In cases of alcohol use disorder, the patient has aspiration, patient is malnutritioned, and there is impaired neutrophil function. In neurologic disease, again, the patient has frequent aspiration, impaired clearance of secretions, and cough. In cases of heart failure, patient has edema fluid and impaired lymphatic drainage. In patients with chronic kidney disease, there is always hypocomplementemia, impaired macrophage and neutrophil function, and reduced humoral immunity. In case of malignancy, there is impaired immune function, altered colonization, and effects of chemotherapy. With HIV, there is impaired cell mediated and humoral immunity. And in cases of diabetics, and in case of diabetics, there is impaired neutrophil, and in case of diabetics, there is neutrophil function, impaired neutrophil function and cell-mediated immunity. Uh, then we have certain other causes as well, which may lead to this condition, and this includes unusual pathogens, which we have already discussed. And then coming to the approach to a non-resolving pneumonia patient, we have already discussed this. First of all, you're going to assess the risk factors for delayed resolution. There has to be क्या assess for risk factors and delayed resolution, that is age, comorbidities, severity of pneumonia, and specific pathogen. The next thing is that is the rate of resolution appropriate? So yes, if the rate of resolution is appropriate, then you should continue therapy and observation. If no, repeat history for clues to unusual pathogens and non-infectious causes. Chest CT and lab tests, they should be done. And based on that, if there is diagnosis which is apparent, then you should modify the treatment accordingly. If they are inconclusive, then you have to see if there is a parenchymal lesion. If due to the parenchymal lesion on CT, the diagnosis is if the diagnosis is not apparent, then in these patients you should undergo a bronchoscopy. Or if there is a mediastinal or peribronchial lymphadenopathy, then in that case also you should undergo a bronchoscopy. And if all these would not yield a result to you, then in that case you should consider surgical lung biopsy, right? Then there are certain unusual pathogens causing a non-resolving pneumonia. So MTB is seen in older adults, immigrants, and HIV positive patients. NTM is seen in patients with COPD or HIV positive patients. Nocardia is seen in immunocompromised host. Actinomyces is seen in aspiration risk, chest wall involvement. Aspergillus species may be seen again in immunocompromised host and where there is evidence of vascular invasion. Then there are various fungi. Chlamydia psittaci or psittacosis may be seen where there is avian source of infection. Francisella tularensis is seen where there is exposure to rabbits and ticks. Uh, Burkholderia pseudomyeli is seen in Southeast Asia due to rodent exposure and it also mimics tuberculosis. Paragonimus westermanni is seen in Asia, Africa, Central and South America. And then we have Bacillus anthracis, which is more common in Asia Minor, Iran, Turkey, and other countries. So, with these hints, you may be able to, uh, get a hint of the causative pathogen. So, with this, we end the discussion and hope you enjoyed it. Thank you.